We're going to review diastolic dysfunction, basically based on the new echocardiogram guidelines that just came out July 2025. So the big question is like diastolic dysfunction is the same of heart failure with preserved ejection fraction. The answer is no. Diastolic dysfunction is a part of heart failure with preserved ejection fraction. Heart failure with preserved ejection fraction is a clinical diagnosis. What does mean in clinical diagnosis? You need to have signs or symptoms of congestive heart failure, such as clinical, physical, laboratories such as elevated BNP, imaging, and echocardiogram. You can have like diastolic dysfunction or invasive. When you do like a right heart cath and you have like elevated pressures, and then you have like signs, you can diagnose the patient with heart failure. The ejection fraction also has to be preserved. Preserved meaning more than 50%. And also there is a caveat. You don't have to have like those diagnoses that you see here in table 9, meaning you don't have like restricted cardiomyopathy. You don't have a, any valvulopathy, for example, mitral stenosis. You don't have anemia even. And you can see that there is a plenty of diagnosis that if the patient has, you can not diagnose the patient with heart failure with preserved ejection fraction. You can use other criteria, yes, but in the right clinical context. ACC and European guidelines. This table is taken from like the new guidelines. Pretty much, I added this table to show you that basically they agree in the core principles that the ejection fraction you have to have like more than 50%. That we already talked about. You have to have like clinical signs, laboratory, echocardiogram, and if, for example, the echocardiogram is inconclusive, you may perform a right heart cath in the patient, and then like figure out what is the pressures, and you can diagnose the patient with heart failure with preserved ejection fraction. Why is this important? For example, you have like a normal diastology. You have like a normal left sided pressures. You have heart failure with preserved ejection fraction? No. In the other hand, you have like clinical symptoms of congestion, and you have like a normal diastole. Then you can diagnose the patient with heart failure with preserved ejection fraction. In order for being a more simplistic view, you can apply a score. Back in 2018, Dr. Reddy came out with a score. What is that score? Is a HFpEF score. HFpEF score has like 6 parameters. If you are obese, more than 30 kilograms, you are hypertension, but you take like 2 or more anti-hypertensive medications. You have atrial fibrillation, paroxysmal or persistent. You have pulmonary hypertension. You have like more than 60 years old, or you have like echocardiogram signs of elevated field pressures. If you have more than 5 points here in the validation, you're going to have like a probability of 90% of having heart failure with preserved ejection fraction. That's why like this sum up to 9. For example, if the patient is more than 30 kilograms, and the patient has like atrial fibrillation, and the patient has signs of congestive heart failure, you can diagnose with heart failure with preserved ejection fraction this patient and start treatment to avoid dreadful consequences. Back in 2016, the old guidelines tell you basically for evaluate diastology in echocardiogram, you can base in 4 parameters. If your average E over E prime is more than 14, the E prime is less than 7 or less than 10 lateral, lateral like tissue Doppler, the TR velocity is more than 2.8, and the LA volume index more than 34. You have like more than 50% diastolic dysfunction, you have like less normal diastole. We're going to review what is all of these parameters means and how you obtain. Then they tell you have like a normal diastole, you should focus on E over E prime, over E over A. So E over A more than 2, you're going to have elevated left atrial pressure is less than 0.8, but the E prime is the E velocity is less than 50. You have like grade 1 diastolic dysfunction, but the normal left atrium pressure But if you're still symptomatic, you can consider like a stress test. So when you have a combination of between all of those parameters, you may use other parameters to see like if you have like a elevated left atrial pressure. In order for further talking about like what is diastolic, I put in this image to show you what is the normal cardiac cycle in order for you to understand what is all of those parameters. Normal cardiac cycle, we have like systole. Systole means like when the blood is ejecting from the LV, and diastole. So what is the important? In diastole, when diastole start, many will say like start when the mitral valve opens, and that's true. But in echocardiogram, I like to think like diastole start when you are not injecting more blood and when the aortic valve closes. Why? Because you have like isovolumic relaxation time. What does that mean? The LV is not injecting more blood, the LV pressure is dropping, and then the LA pressure is higher. That's what like opens the mitral valve. When opens the mitral valve, you have like three parts here. You have like the rapid flush of blood to the LV. That is called like a rapid inflow of blood or rapid ejection time. Then you have like blood going to the from the LA to the LV in diastasis, and then you have like the atrial systole. They say like 20% the atrial systole, the volume upward to the total like volume of the LV. Then you are gonna see in the echo. In the echo is the same thing. You have like the E wave and the A wave. E wave meaning this rapid inflow. You are gonna see in normal individuals, the E wave is bigger than the A wave. The A wave just was like a 20% of the volume. That's why like E over A is gonna be more than zero point 0.8, but less than 2. Why is less than 2? We're gonna talk later about those things. DT, what is DT is a this is this acceleration time. More than 140 is basically it doesn't tell it's not like a elevated left atrial pressure. 140. Remember that name? The number we're gonna review later. This. Now, what is this? This is a tissue Doppler. The same thing. You have here rapid inflow. You're gonna generate the E wave, but at the same time, the muscle is smart that is gonna generate a relaxation here. That is what we call E prime, and the A prime also to receive the A wave. What does that mean, like LV filling pressures? LV filling pressures, many people were confused, meaning is the wedge, is the left atrial pressure, is the mean LVDP or the LVEDP, left ventricular diastolic pressure or left ventricular end diastolic pressure. So in order for explain what is LV filling pressure, we have to tell like in early diastolic dysfunction, you can have increase of LVEDP, meaning this pressure here, with a normal left atrial pressure or a wedge pressure. Remember that this is a continuous circuit. The wedge pressure and the LAP sometimes equate. That's why like when you have this increased LVEDP or diastolic dysfunction grade 1, you can actually prescribe exercise echo because tachycardia and increase of LV afterload is going to increase the LA pressure. LA pressure increase, wedge increase pressure in the lungs. That's what is causing like dyspnea. The new guidelines tell you you have two steps to diagnose diastolic dysfunction. Step one, no more focusing the four parameters, focusing the E prime. Why? Because it's a reliable marker of impaired LV relaxation. Either E prime, the septal is less than 6 and the lateral is less than 7, you go to step 2. By the way, less than 6 and less than 7, we reviewed that was less than 7 and less than 10. Less than 7 septal and less than 10. Here we're gonna see in a little bit why is this 6 and 7. Then in step 2, you are gonna see all of those parameters to see if you have elevated left atrial pressure. Why? Because that is why you care. And then you can diagnose. If you have E prime reduced, you only have one parameter in step 2, and then you can diagnose the patient with diastolic dysfunction. But if E prime is normal, you have to have 2 or more markers of step 2 to diagnose diastolic dysfunction. So in step 1, the E prime, you're going to see the E prime septal less than 6, less than 7. In table 6 here, they present you like 20 to 39-year-old, less than 7, less than 10. That was in the old guidance, right? But look, more than 65 years old, less than 6, less than 7. So why is this value chosen? Because this is sensitive. This is sensitive to recognize patients with diastolic dysfunction. Less than 6, less than 7. No more less than 7, less than 10. You can use in those ages, but this is the recommendation, less than 6, less than 7, irrespective of age, or the average less than 6.5. This is the same thing. Tissue Doppler, E prime is going to be during the rapid filling, is for the LV to receive that blood, and the A prime as well here. Step 2, you're going to have like various parameters, but they focus in E over E prime, more than 14. This is a new parameters, large, less than 18, E over A prime, 0.8 or more than 2, and the left atrial volume index more than 34. So here you can see E prime. E is a rapid filling, and it's going to be equal to E prime. Why? Because the LA is contracting and the LV is receiving the blood. So the muscle is smart enough to receive that blood when you have like a rapid filling. And the same thing with A prime. The acceleration time you can calculate here from the peak to the base is less than 140. That is going to tell you like elevated left atrial pressure. Why? Because you don't have like enough time to equalize pressures from the LA to the LV. Large. What is large is peak positive strain value during ventricular systole. So you're gonna have like a sample here in the LA, and is the 18 is the cutoff. This marker is not widely used in clinical practice. Probably like in the future is gonna become more familiar to many clinicians, but right now we don't use it in the normal clinical practice. But this is important. This we use all the time, E over A prime. In the normal individuals, we already talk about it. In the systole, the LA is going to receive blood from the pulmonary veins, right? Once, like the mitral valve opening, all the blood gush going to the LV is going to generate like a E wave, which is going to be bigger than the A wave caused by the atrial contraction. But imagine like like your LV is stiff, right? Meaning if stiff, like the E wave is not gonna be as high as here. Why? Because the pressure are gonna equalize so rapidly. It's not gonna be compliant. That's why like your E prime is gonna be low. So that's why like you are gonna have like switch of those things. E over A is gonna be less than 0.8. Why? Because it's gonna reverse. The atrial contraction has to do like an extra effort to squeeze that blood into the LV. But then, irrespective your LV is stiff, imagine like your LA is becoming bigger and bigger and bigger because you cannot push more blood there. Then doesn't matter. Your E is gonna be high because all the blood that is accumulating LA in the left atrium is gonna go like suddenly to the LV, and it's gonna generate like a bigger E, bigger E, but the deceleration time is going to be less than 140. Why? Because even though like the pressure is so high, higher than the LV, the equalization is so rapidly. And the A is going to be like minuscule. Here it's going to be small. Why? Because like the atrium cannot contract against like a high pressure in the LV. So that's why like back in the old guidance you had like E over A, you had like a abnormal grade 1 diastolic dysfunction. Then you have like pseudo normalization, which is grade 2, and grade 3 is E over A is more than 2, the ratio. The LA volume index more than 34. Why is index this? Is because you have like a person who's 7 foot, or you have like a person who like 5 foot. It's not gonna be the same size. But if you index it by the BSA more than 34, that tells you like it's bigger by the body size. That if this LA volume index is normal, that tells you like normal LV-EDP. Why? Because like the pressure in the left ventricle is not that high, so the atrium doesn't have to be compliant to that huge amount of blood. So you don't have to use those in athletes, atrial fibrillation, atrial flutter, or mitral valvular disease. Why? Because in those type of patients are going to be abnormally enlarged or normally enlarged in the athletes just for adaptation here in athletes. But the atrial fibrillation, atrial flutter is going to be abnormally enlarged. Mitral stenosis, you have the atrium is going to push again like a narrow orifice, so it's going to be enlarged either way. So it's not reliable in those cases. The using the left atrial volume index. So diastolic dysfunction again. E prime tell you like abnormal relaxation. Then you have to find out if the LA pressure is higher or normal. E prime is reduced. One more markers. You have to use just one more marker for diagnostic diastolic dysfunction. If the E prime is preserved, you need like 2 markers to diagnose diastolic dysfunction. And then, what is important of this slides? Because you want to know like, okay, I have like a abnormal diastology. I need to know now know like what is the pressure in the LA in the left atrium? Is elevated or is normal? And this is a diagram. Just tell you the same thing. Reduce relaxation, E prime. Reduce less than 6, less than 7. Then you go like to the step 2. You're gonna see E over E prime, septal or lateral or average more than 14. If this is abnormal, this is gonna increase the right side pressure, so it's gonna increase the TR velocity more than 2.8 or more like pulmonary artery systolic pressure more than 35. If all of those are normal, or you have like only reduced E prime, for example, and the E over E prime is a 0.8, you by itself are gonna have like a normal left atrial pressure. But imagine like you have like a normal relaxation, and the patient tell you like, "Oh, doctor, still I have like a dyspnea on exertion or dyspnea when I am walking fast." Then is a recommendation to do a diastolic exercise echo. Why? Because during the tachycardia, increase the left ventricular afterflow is going to increase the LA pressure, and that is going to increase the wedge pressure. Is going to increase like the pressure in the lungs. That's going to give you dyspnea. If all of those are abnormal, you're going to see E prime reduced, E over E prime more than 14, and TR velocity more than 2.8. All are normal. That tells you increase left atrial pressure. Now, if the E over A prime is more than 2, grade 3, diastolic dysfunction. Less than 2 is a grade 2 diastolic dysfunction. Now, imagine like you don't have this combination here. You don't have this two, you just have like one abnormal here. Then you have to use all of these parameters that we're going to talk later. Again, in this yellow, dark yellow table are the conditions that you don't use those parameters. For example, atrial fibrillation, MAC, MR, MS, you have like a history of transplant or pericardial constriction, etc. So we're going to put an example. MR, what happened in MR? MR, in systole, you are going to have like blood going to the LA, right? More blood going to the LA is in systole. What does that mean? More blood in diastole going to the LV. So the E prime is gonna, the E velocity is gonna be higher. So that is why like in the MR you don't use. What happened in the MS? MS, you're gonna have like a narrower orifice, so it's gonna be hard for the LA to like squeeze blood into the LV. This is like a picture of TR velocity. So you put it like a continuous wave Doppler through the TR velocity, and you're gonna see like velocities here. For example, here the velocity is around like almost 4 here in the right side of like your images is almost 3, 3.3. And this is the Bernoulli equation. The Bernoulli equation you can use to calculate the difference of pressure between two cavities when you have like when you know the velocity. For example, 3 times 3 is 9 times 4 is 36. 36 is the difference of pressure between the RA and the LV. If you added the right side pressure, you can know like uh, the right ventricular systolic pressure, which is going to be the same as the pulmonary artery systolic pressure. And you can know based on this Bernoulli equation. What is the normal values of the LVEDP and the wedge pressure? Wedge pressure slash LAP or left atrial pressure. Normal values at rest is more than 16, more abnormal values, sorry, more than 15, with exercise more than 23 and more than 25. You see like anything in particular here, the values of the LVEDP is all closely normal to the closely like similar to the wedge and the exercise as well. So when you do a patient left heart cath and you find out the LVEDP, you can rely those things and you can say like, okay, the wedge pressure is elevated. Imagine like you do like a left heart cath in a patient who has a LVEDP of more than 25. You know like the wedge pressure is 25 around so the patient may need like diuresis. So what is other parameters that tell you like increase LA pressure or filling pressure that is going to be equal to heart failure with preserved ejection fraction? Remember this, diastology, abnormal diastology doesn't mean a heart failure with preserved ejection fraction, but increased LA pressure means heart failure with preserved ejection fraction in the right clinical context. 99% of the time, increased LAP, the patient is going to be short of breath. So you can diagnose heart failure with preserved ejection fraction. I am making it this number 99%. I could be wrong. So E over A more than 2, that tell you increased LAP. And how you see in the mitral inflow, E is going to be more than 2 the ratio through to A. Also, you can see here the deceleration times less than 140. You can say like, oh, the patient has increased LEP. If the E prime is less, then you can say the patient have a grade 3 diastolic dysfunction. Patient has like symptoms of heart failure with preserved ejection fraction. I'm going to start treatment. Now, in exercise, why when you have like a normal E over A normal or less than 0.8, why exercise is recommended to do exercise echo? Because exercise increase the E prime 5 centimeters over second. And what does that mean? If the exercise increase 3 or 5, that is gonna reduce your E over E prime. But if you have a normal diastolic, that is not going to be increased. So that is going to be increased E over E prime, and then you have like increased LAP. This is the same thing. E over E prime more than 14 is highly specific. Less than A is normal. Don't use in those kind of conditions. And you can see here, E prime, imagine that you have like a normal relaxation, is going to be smaller, and E wave is going to be high. So the ratio is going to be higher, more than 14. So when you have like a grade 1 diastolic dysfunction back in the old guidelines, and you prescribe the patient, we have to do an exercise echo. In normal individuals, the E prime is going to increase 3 to 5. But if you have a normal diastole, the E prime is going to increase, but the E prime is going to be is going to stay there. So you're going to have like an increase of this E over E prime more than 14, and then you can diagnose the patient have heart failure with preserved ejection fraction. The TR velocity, we already reviewed, continuous wave Doppler. You're going to have like a maximal velocity based on the Bernoulli equation. You can calculate the pulmonary artery systolic pressure more than 35. That is a criteria to elevated LA pressures. You can also use the pulmonary vein. Why the pulmonary vein? This is assistance, right? This is abnormal. In systole, what you're gonna have in systole? In systole, you're gonna have like more blood going to the LA in normal individuals, and less blood in the diastole. So what is happening here? Why you have when you have reversal here is over there less than 1, because in systole you already have elevated left atrial pressure, so no more blood is going there. So you need to open the mitral valve to allow the blood coming from the veins going to the LA. So that's why you have reversal, and it's less than 1. In the guidelines says 0.65, so but you can keep like less than 1, that is fine. Large less than 18, interventricular relaxation times less than 70. Why is this number good? Why? Because when you have elevated left ventricular pressures, right, and elevated left atrial pressures, when you are coming out of the systole, the pressure, the relaxation during that time, the LA pressure is highly elevated, so it's gonna shorten this time, less than 70. If you have like more than 110, it's normal LAP. This is useful when you have like a patient with a mitral annular calcification. And this is how you calculate here. How you calculate here. So the the left ventricular relaxation time is going to be shorter because the LA is has like higher pressure, so it's going to overcome the pressure on the LV once like the mitral valve is open. E over velocity of a BP more than 2.5, it tells you like the wedge pressure is more than 15. What is the velocity of provocation? You use like a Doppler end mode, and you are gonna see here, you put the cursor here in this, you're gonna see how rapid this velocity of provocation goes. That's what I tell you what is the relaxation of the LV. For example, if the relaxation is not that good, right? And the E prime is high, and the relaxation is not that good. So that is going to tell you like more than 2.5 equates to a wedge pressure more than 15. This is load dependent, and you don't have to use in normal when the patient has like a normal EF. So this parameter is more like when you have like a reduced ejection fraction to see diastole. L wave more than 50 and S. L wave the same thing. You see like the mitral inflow, E over A prime, and the L wave is in the middle, but has to be more than 50. So here you see more than 50. This is IL wave. It's less than that. In bradycardic could be normal. So we already talked about how like the pulmonary artery pressures can give you a correlation with the wedge pressure. But you can calculate that the pulmonary artery and diastolic pressure based on this, and when you have like a PR velocity, at the end you can see what is my wedge pressure. The AR minus a duration more than 30 milliseconds tell you like increased LA pressure. What is that? Imagine like you have like elevated left ventricular pressure. So the LA started to contract. The blood is gonna follow like the less compliant, the high, less resistant like path. And what is the less resistant path in that case? It is the pulmonary veins. That's why if the atrial duration is more than 30 milliseconds, that tells you elevated left atrial pressure. And Valsalva maneuver you also can use if the decrease on the E over A ratio is more than 15%. That is a positive Valsalva maneuver, and this is load dependent. So you make the patient to do a Valsalva maneuver as this, and you are gonna see how the E over A ratio is gonna flip. And has to be, by the way, for a good Valsalva maneuver, the E prime has to reduce at least 10% if you want to say like a good Valsalva maneuver. You can use also all the parameters to see like, oh, this is a high LVDP. Remember, having high LVDP doesn't equate to having like a increased LA pressure. You can have high LVEDP and you can have like normal left atrial pressure or wedge pressure, but these parameters can tell you. We already talked about like diastolic this acceleration time less than 140, aortic regurgitation more than 35 in the pulmonary vein, this aortic regurgitation, atrial regurgitation minus aortic time more than 30, or A duration, A wave less than 120, or the L wave. So this is my reference. Hopefully I was clear. So again, in a nutshell, diastolic dysfunction is becoming easier and easier, and with these new guidelines, I think like the simplification is even further like improved. Why? Because now you have to see like the E prime. The E prime is the relaxation. E prime is reduced, then you have to see all the parameters. E over A, is more than 14, you have like elevated elevator pressure. The TR velocity you can also use, and you can use also all other parameters. Thank you for watching, and see you next time. Bye bye.